Hi, this is Lindsay Sullivan back live at Bone and Joint Institute with our monthly Facebook Live series with our physicians talking about various conditions and surgeries that we treat here at Bone and Joint Institute. Today I have Dr. Todd Wurth with us, and we are going to be talking about shoulder replacement, different types, indications for, things like that. But Dr. Wurth, before we get started, just tell me a little bit about yourself, about your practice, about your specialty.
Yeah, so I've been in Franklin since 2004, straight out of training. So this is my first and only job ever, and so obviously our practice has changed a little bit over the last several years. But my subspecialty is basically upper extremities. So I do shoulders to fingertips, and that's what I did my fellowship in. Obviously, I still do general orthopedic surgery for call and whatnot, but my area of subspecialty is upper extremity.
Okay, and you're the team physician out at Nolensville High School as well?
Correct.
Okay, awesome. So today we're talking about total shoulder replacement, but to get to shoulder replacement, let's kind of back up a little bit and just talk about arthritis in general in the shoulder. So can you talk about that a little bit?
Yeah, so arthritis, you get arthritis from different things. Obviously, we have general osteoarthritis that people develop. Basically kind of your wear and tear arthritis. There are inflammatory arthritis, whether it be rheumatoid arthritis, psoriatic arthritis, or something like that. And then the very common one that we see is post-traumatic arthritis. Someone who has injured a joint, in the case of the shoulder, perhaps they dislocated their shoulder.
Okay.
And when they dislocate their shoulder, they injure the cartilage. And that may have happened when they were a teenager, and then by the time they're 40 or 50, if they had an injury to that cartilage, that results in post-traumatic arthritis where the shoulder joint begins to wear significantly potentially.
Okay, so with an injury such as that or the osteoarthritis, what are some treatments that you offer in your clinic? Start with conservative, and then we can kind of move to a more surgical route.
Yeah, with any arthritis, non-steroidal anti-inflammatory medication is pretty much your first go-to. You can consider injections, corticosteroid injections that are done prudently and not too often. I typically tell people, try to keep it a cortisone injection once every 6 months if possible in any one particular joint. If you get them too frequently, then it can speed up the arthritic process. Other options such as PRP injections are possible that they can help if it's early in the arthritic process. Other avenues such as stem cell treatment that's just not there yet. That's not been shown to try to regrow. A lot of people do stem cells, think they're going to regrow cartilage, and it's just that technology is not there yet.
So let's go into a more, if conservative treatment doesn't work or it's an indicator for surgeries, talk about total shoulder replacement for a little bit.
Yeah, so leading up to that, another thought, people often will discuss is physical therapy. If I've got someone who has a significantly arthritic shoulder, I typically don't send them to therapy. I mean, now, don't get me wrong, I want to make sure that we keep their rotator cuff strong if they have a functioning rotator cuff. But as a shoulder, like any joint, becomes arthritic, as it becomes more arthritic, it becomes stiffer. And so if you just try to push through and try to get more motion, you're just going to aggravate the arthritis. And so I usually don't recommend doing that. As far as when to do surgery, that's a common question. People come in and say, "Hey, should I get my shoulder replaced?" And my answer to that is that when the shoulder in this situation, when it starts preventing you from doing the things you want to do, you want to do with your daily life, or the things that you need to do with your life, then you think about doing the replacement. I mean, and obviously you have to take other things into consideration: your age, medical comorbidities, and what kind of stuff. But when it starts to affect your life, it's a good option.
It's a good option.
And when everything else has failed, obviously.
And talk about, I know there are a few different types of total shoulder replacement. Can you talk about those?
Yeah, so we do shoulder replacements for basically 3 reasons. Number 1, arthritis. Number 2, we do it for something called pseudoparesis in situations where, patients may not have a functioning rotator cuff, or they have a nerve-related disorder that has rendered their rotator cuff ineffective. Then, they may come in and they have an inability to lift their arm. But as long as the other larger muscles around the shoulder are working, the deltoid, the latissimus, the pectoralis major, then we have surgical options that will accommodate that. And then the third situation that we do replacements is for fractures.
Okay.
So a lot of patients come in and they'll have a bad fracture that involves the attachment of the rotator cuff, or the head of the humerus is split and you've got a lot of articular pieces. Then we'll do a shoulder replacement for that. I get questions a lot. I mean, there are two basic types of shoulder replacements. There's an anatomic shoulder replacement, and then there's something called a reverse total shoulder replacement. A lot of people really don't understand what that is, so I brought a model. When we do a shoulder replacement, basically the shoulder is, we'll start out with an anatomic. So the humeral head is if you can imagine, this is a replaced, so this is an anatomic replaced humeral head. So to do that, the normal head, we'll cut that head off, and it's arthritic. We'll drill down inside the bone, we put a component down inside the bone, and then we replace the humeral head with a metal head that is matched perfectly for that particular patient. And then on the socket side, in a patient who has a good functioning rotator cuff, then we'll replace the arthritic socket or the glenoid with a plastic component like this. And so basically, then you have metal on plastic, and so that gives you relief of your symptoms. For patients who do not have a functioning rotator cuff, the rotator cuff, basically the job is to keep the ball to the socket, and it provides stability to the joint. So if you don't have a functioning rotator cuff, when you bring your arm up, the humerus rides up on this other bone and they can't pull it up. And so in that situation, we consider doing something called a reverse total shoulder replacement. And so on the reverse total shoulder replacement, on the socket side, rather than having a plastic insert to recreate the normal joint, we will place something called a base plate on it. And so this base plate, actually, it's metal. It has a metal cage that goes into the bone behind it. And then typically we'll augment that with screws to provide initial stability. The bone will grow through the holes in the cage, and so basically the prosthesis kind of grows to the body and provides long-term stability. On top of that base plate, then we put this component. It's called a glenosphere. So basically the ball becomes on the socket side. And then on the humerus side, we can use that same stem, we make that same cut, but rather than having a ball, we'll insert a component that looks like this. So now the plastic is on this side, and so when you reduce the shoulder, you can see that you have stability to the shoulder. So you don't need that functioning rotator cuff. And so the other large muscles around the shoulder will bring the arm up will allow you to bring the arm up without the presence of rotator cuff. And so that's an excellent option. You may say, and the one thing I would say is reverse total shoulder replacements, by and large, are a little bit easier to rehab than a standard shoulder replacement, because with a standard shoulder replacement, you have to repair a part of the rotator cuff on the way out. Basically, you have to release part of it to get the prosthesis in, so you repair that on the way out. So you have to protect that during the rehab process. So, for 6 weeks, you're in a sling and a pillow, and then we begin active range of motion at 6 weeks. I do basically the same thing with the reverses, although we don't have to worry about a rotator cuff repair with that necessarily. Although I will repair the rotator cuff if there are portions of it that are repairable, even with a reverse. But the stability of the implant just allows it to rehab a little bit better. So why don't we just do reverses for everybody? Base it on a couple of things. In the United States, reverses are basically outnumbering anatomics and the ones that are being put in, but I still think that a well-functioning anatomic shoulder replacement is better than a reverse, particularly with internal rotation, reaching up behind your back. Reverses are a little bit harder for that, but both, in my practice, I tailor what I do to my patients and their needs. So.
And speaking of tailoring, what types of technology do you use when you're in surgery?
Yeah, so I use intraoperatively CT guided navigation for placement of the glenoid component. And what I mean by the glenoid component, it's the socket side. And so basically what we do is we obtain a CT scan preoperatively. And so it'll give me a three-dimensional image of the glenoid. And so basically on a laptop or a tablet, I can rotate this around and I can put this component exactly where it needs to be. in shoulder replacements, if a shoulder replacement is going to fail, it's going to fail or loosen typically on
over there. Okay.
the socket side. And so you want it in the very best position that you can get it. And so the preoperative CT will allow us to have the patient's anatomy. In surgery, basically, I attach a tracker to this little process called the coracoid.
Mm-hmm.
And then I have a handheld tracker that will touch different areas of the anatomy. And then I have intraoperatively with live guidance via CT. I can perform my drill for this placement, place the screws under live CT guided navigation, and it's just particularly in instances where you've got a lot of bone loss. There are augments that we can do where the prosthesis for the glenoid side will have buildup with the metal, and it'll take up for that loss of bone. And so the CT guided navigation just allows you to kind of tailor the implant to the patient, and that gives them the best option for long-term success of their implant.
Awesome. And thank you for that. Really having the models there really kind of just visualizes it. So that's great. Thank you. So taking a step back and looking at Bone and Joint Institute as a whole, kind of describe the comprehensive care that we offer here, and how does it help the patient experience from start to finish?
Yeah, well, you know, it's ours is a little bit unique in that even it starts with even the physicians. I mean, we'll have patients come in, they may be from out of state, and they'll see one provider, and you know, it's not uncommon that I'll have one of my partners come down and they don't do total shoulder replacements, or they're in a different specialty, but they have a patient who comes in for that. And they're there to discuss shoulder placement, and they're say, hey, will you come down and talk to this patient? And so, you know, we'll make adjustments like that, you know, the same day. The other thing is that, you know, we have CT availability in our office, and so we can get the CT scan preoperatively in the office. We have all the templating and everything else in the software here. You know, you can have your surgery. We actually do shoulder replacements as an outpatient, depending, typically, well, non-Medicare we do at present. Medicare will eventually get there. They've gotten there with hips and knees. And so I'm sure that they'll get to the point fiscally that it makes sense for them to do that. Absolutely. But we do outpatient surgery here with shoulder replacements, and then we have our full physical therapy line afterwards, in which they can provide, you know, they can obtain all their post-op rehabilitation here as well. And then even out in the community, we've got different satellite locations. Just opened our 5th physical therapy clinic just 2 weeks ago. So it kind of spreading and meeting our patients where they work and live. So that's great. Well, Dr. Wurth, thank you again for your time today. We appreciate it. If you have any questions for Dr. Wurth or want to schedule an appointment, you can give us a call at 615-791-2630 or visit our website at boneandjointtn.org. Thank you again for your time today. I appreciate it. You're welcome.
Thank you.